Present. Welcome, everybody. My name is Jennifer Lemus, and I'm Lead of Outreach. And today we have Dr. Syed. And before we begin with him, I'm going to briefly give you some slides on what pre-health shadowing is and what we do. Sorry. Okay. So, sorry, that was. Okay. We are Pre-Health Shadowing, an international nonprofit organization, and our mission is to empower aspiring healthcare professionals by providing virtual shadowing opportunities. We're thrilled to have you here as part of our community. Your participation and support is crucial and are driving forward in our community. Your participation and support is crucial in driving forward our shared goals in the medical field. Okay. As part of our commitment to inclusivity, we provide closed caption to support students with all abilities and needs. We value the feedback and are always looking for improved accessibility. If you have any ideas or suggestions, please email us info@prehealthshadowing.com. To ensure communication doesn't get lost in your spam or folder, please save us as contacts. By joining our email list, you'll never miss an update. Sorry. If you want to stay in the loop, informed, we have tons of social media. We have Instagram, TikTok, Twitter. YouTube is more of where you find our videos, Facebook and LinkedIn. Don't forget to sign up for our email. The best way to ensure you're always informed of our latest session and opportunities. So we're thrilled to welcome students from all over the globe and also all over the States. If you don't mind dropping in where you're from in the chat box, we'd like to know where you're joining in from. I'm joining in from Los Angeles. Okay, we got Canada, we have Jersey, Virginia. We have Canada, Los Angeles, Bay Area, Texas. We have a very diverse group. Sorry, I keep going backwards. I apologize. Okay, if you're interested in being part of pre-health shadowing, we have a fantastic opportunity for you to join as a volunteer. There's also information on our chat box, so you can click there and start your process. You get started registering our website, again, valuable experience, and make a possible impact. Make a valuable impact. If you have any questions, feel free to ask or visit our website for more information. We're also recruiting in our leadership team if you want to do more than just volunteer. If you want to go into leadership position, we have that available for you. It's 100% remote, and it's basically a time that you can do it. Just head to our website and fill out the application form. These are the leadership roles that we have available. We have all departments. We have lead of grant, fundraising, video production, research programs, and recruitment. If you follow us on this, follow the link, you can get access to more. And if you feel that there's a leadership role that we don't have and would like to create one, please feel free to do so. If you're in a high school training program, we have that available as well. It's a fantastic way to gain valuable skills and insight in both leadership and healthcare fields before you stepped foot in a college campus. All you need to do is fill in the interest form available on our website. Sorry, I keep going backwards, guys. Okay, we are completely free. Our operation relies on generous donations and invaluable time contributed by our dedicated volunteers. This is what allows us to contribute, offering these opportunities and learning from all backgrounds and walk of life. If you have the means to, please donate, whether it be your time or money. But if not, it's okay. We really enjoy you donating. Just your time would be enough. But if you feel inclined to, here's the way of doing it. You can do our website or this QR code. If you have any questions, please feel free to put them on the chat box, and we will make sure to answer the Q&A after the Q&A. Also, make sure you take good notes. Post-shadowing assessment will be available to take and earn after. So we have a quiz, a 10-question quiz after the session. So this will allow you to earn a certificate. And so please make sure to take good notes. Also, please, if you can please put your cameras on. We'd like to see who we're seeing, and then we can make this more of a interactive as opposed to just looking at black screens. All right, so that's all I got, and I'm gonna give it now to Dr. Syed. Let me close my, sorry, and where did it go? Did I stop again? Dr.
Is that
Syed?
good? Can
Yes.
you guys see can you see the screen?
Yeah,
All
looks
right. All right, great. So, good afternoon, everyone. My name is Shareef Syed. I'm a abdominal transplant surgeon, and I've kind of had. If you would have asked me when I was in your shoes, and I don't know exactly where all of you are, but somewhere in your early 20s or late teens, what I would end up doing, I wouldn't have told you I would be doing this. So, life takes a lot of turns, but I'm thankful that I've ended up doing transplantation. So I'll tell you a little bit about what transplantation is, and then I'll speak a little bit about my journey. So transplant, there's basically two bits to transplant. There's liver, well, abdominal transplant is liver, kidney, and pancreas. So three things in the belly. What is the liver? The liver is kind of like a filter. It kind of filters out, it has all of this structure in the liver that filters out toxins and is an immune organ. And so a clean filter works very well. It's able to filter out everything. But when the filter gets clogged, the air circulation is not so good, or the blood circulation is not so good, and it causes a whole host of problems when your liver becomes scarred and cirrhotic, which is this bottom liver over here. And so it leads to these things called portal hypertension, where the blood vessels, where they would normally just cruise through the liver, become backed up. And it's like a traffic jam of all of these blood vessels, and they can become large and dilated and become variceal. So you end up with things like varices in your esophagus and your stomach. So even though this is what a normal esophagus looks like, a a a variceal esophagus, you see all of these dilated veins all along. These can pop and bleed and cause significant life-threatening bleeding. The other thing that can happen is that the pressure in your belly increases, and as a result of that, there's a huge amount of fluid that accumulates, and this is called ascites. You can imagine that if you have ascites and all of your guts are squished, you don't feel very much like eating. And then, as you can see, here is a classic cirrhotic patient who's got wasting of their muscles, huge abdomen, gynecomastia from, this is a male patient, but they will develop breast because of peripheral conversion of to estrogens. And so, what are the most common causes that we have to do a liver transplant for? Fatty liver disease, hepatitis, and alcohol, and liver cancer. So if you look at the way that we figure it out, we try to order the list in who is most likely to die. And so the people who are most likely to die are people who have a higher MELD score. So if you have a MELD score over 40, you have a 70% risk of dying if you have in 3 months. And so this is 3 month mortality. And the lower your score is, the lower your risk of dying is in the next 3 months. And so we ordered the list in terms of who's got the highest score and who essentially is the highest risk of dying, and they get a liver transplant first. And the MELD score is made up of four things. It's made up of bilirubin, so how yellow you are, and that's basically one of the functions of the liver. Your clotting, the clotting cascade and clotting factors are is another major arm of what the liver does. So your how thin your blood is or how clotty your blood is, your INR also is one large aspect of the MELD score. The the serum creatinine. So if you have renal, if your kidneys are abnormal as a result of your liver, it's a major risk factor, and so that is a part of the score and your sodium level. And so all of these are put into this equation, and then we come up with who's at, who's highest risk at dying. And so then that you say, okay, this person is going to die, they need to get a liver transplant. And so where do we get livers from? So there's two places that we can get livers from. We can get livers from people who are alive and people who have passed away. And so if you look at deceased donor liver anatomy is interesting because the patient has either had um, some sort of injury, like a stroke, a massive bleed into their brain, or a seizure where they've had a prolonged period of time with anoxia from their brain, either due to some sort of neurologic event or from drug overdose. And so they've had low oxygen to their brain, and they go into a hospital, they get worked on for days and days and days, and it seems as though they're not improving. You can do something called brain death studies, where you can go through a whole bunch of tests, they're radiologic, physiologic, and clinical exams, where you find out whether this person's brain is working or not working. And if they meet certain criteria, you can say that not only is the brain working, but the brain is dead. And if the brain is dead, then the patient is dead. And as a result of that, the family get get approached, and if the patient uh, has agreed to be an organ donor, then they can say that they can approach the family to say this person has signed up to be an organ donor. They're brain dead, but their liver, their kidneys, their heart, their lungs are perfectly functional. Would you be okay with donation? And usually, they're somewhat devastated about the situation that's going through their family member, but they are also quite excited to turn this kind of terrible situation into one that is a charitable situation and that can transform the lives of up to six, seven, eight people by donating. And so, in deceased donor liver transplant, it's a lot easier for the uh, transplant because um, you can remove the whole liver, all of the pipes associated with it, because the donor has passed away, and as a result of that, they're not going to be requiring any of this stuff. And so you can there's basically four pipes that is necessary for a liver transplant. You need to have the vena cava, which is this big pipe in the back. The liver is also an interesting organ where it has two blood supplies. It has portal vein, hepatic artery. It's a dual blood supply, arterial and venous blood supply, and then a bile duct that drains out of it. And so, we kind of come up with these ways where you kind of cut through these patches and create this corral patch and then suture it together. And as we've got better at sewing, we've we have less complications when suturing these blood vessels together. Living donor liver transplant is a little bit more complicated because you have to split a living person's liver in half. And so the thing that you absolutely want to do is not cause any harm to the living donor's health, because this human is basically uh, going through something just for charitable purposes. They just want to donate a chunk of their liver to help their mom, their dad, their child, uh, or some people just donate for the sake of being nice. So there's altruistic donors who say, I'm ready to donate one of my kidneys or half of my liver for a person I don't even know. Interestingly, we got very good at doing this procedure, donation with open surgery. So we kind of divide the liver in half, make sure all of the blood supply going to the liver is preserved, and then because we can't divide anything that the donor needs afterwards. But then we can take the if we make sure of that, then we also have to make sure that when we take out the other side of the liver, we take out pipes on either side that are going to be good enough quality to suture in another human being. So overall, it's a higher risk procedure for sure. But we've developed a lot of core techniques, and I'll get to that later in terms of how we do that. Anyway, so then this is a whole liver transplant. This is the heart beating above, and then this is the liver being sewn in, and then you're kind of looking at uh, the blood flow being restored. So here you can see it looks kind of pink and nice, but otherwise it looks a little bit. And now once you open this pipe, you'll see that the liver pinks up quite a lot. And so it's this kind of this miracle where the liver is kind of brought in ice, and then it comes to life again. So it kind of comes out of the recipient. When you put the liver in a an ice box and then you take it out and then put it into another human being, there's a lot of stuff that accumulates within it. And what can happen is that it can cause a period of instability after you unclamp it. And so this is what is called reperfusion syndrome, where if you see here that you have these things called peak T waves, hypotension, and then and and um and bradycardia. Yeah. And so this is the and so it is an interesting time during a liver transplant. The anesthesiologist at that time will give blood pressure medications, treat for high potassium levels, and usually things work out pretty good. But there's a moment of about 5, 10 minutes after you unclamp a liver that it can be a little bit dicey. Bleeding is, some patients have bleeding, neither blood transfusion. Sometimes we need to take them back to the operating room for bleeding. Bile duct narrowing or leakage happens in about 15%. Clotting of the hepatic artery, about 1 to 3%. Infection and kidney injury happens after. So, you know, we talked about how likely they were to die. So all of these people will have, um, somewhere between a 70 to a 20% chance of dying in the next uh, 3 months. And then after your liver transplant, where do we have that? Do we not have risk versus benefit? Here we go. So adult, is this, oh no, this is liver. So then if you look at 1 year graft survival, I think ours is a little bit better now. It's about 96% 1 year patient survival, 100% for pediatric So, you do all of this, and then 3-year graft survival is about somewhere about 89% now, and graft survival is about 85%. So you see here, especially in the children, it works incredibly well. And then for adults, there's a lot of reasons why certain people don't derive a huge amount of benefit, but most people derive, they go from being on death's door to living a completely normal life, which is incredibly rewarding for those of us who do it. And then there's kidney transplant. When they first started doing kidney transplant, they didn't really know where to put it, so they kind of made a hole in the leg and connected it to some leg blood vessels. But basically, the kidneys are a bit more straightforward. There's two pipes. Essentially, there's a renal vein, renal artery, and then one pipe leaving with the urine called the ureter. And so, living donor kidney transplantation is really incredible thing where the graft survival is incredible after a living donor operation. The living donor operation also, for a long time, has been minimally invasive. We used to do it laparoscopically. We still do it laparoscopically, where the donors only get these tiny little incisions and then an extraction port here when removing the kidney. And then when we pop it in, we put it in, we make this little incision here next to the belly button. Then we sew in the artery and the vein, low down towards the leg, and then it's close enough just to plug the ureter in straight into the bladder. And so it's a relatively low complications operation now that we do. At UCSF we do somewhere around 400 to 500 kidney transplants. So you're almost like a machine at doing these procedures. And then pancreas transplant is another interesting concept. It's a little bit more finicky than kidney and liver because the pancreas is, a gland essentially, and so it doesn't have a nice coating around it. It has a very thin capsule, and so people who have type 1 diabetes uh, and and concomitant uh, end-stage kidney disease, we do simultaneous kidney and pancreas transplants. So the patients have a cure for their diabetes, which improves their quality of life. It means that they don't have to take insulin anymore, and they get a cure for their dialysis and the end-stage kidney disease. So simultaneous kidney and pancreas transplant is what we usually do. So what are the risks? Rejection is a huge issue in transplantation historically, but nowadays with calcineurin inhibitors, the risk of rejection is low as long as patients take their medications. There's a period of time where pediatric patients, when they transition to being young adults and mom and dad aren't looking after their immunosuppression and they're feeling good, they sometimes stop taking it, or if people have insurance issues or social issues, then often they stop taking the immunosuppression medications and that leads to rejection. But it's very rare that if you take all of your immunosuppression medications, you usually do pretty good. So this slide we already looked at. And then, recently I've sort of stop sharing. Which one should I use? This one. Okay. Let me show. Let me just share my entire screen share. Okay, and so then, when I was talking about um, liver or kidney surgery. For a long time here, we've been doing minimally invasive kidney donation, but liver donation we haven't been doing. There's this thing called the Da Vinci robot that came into production probably about 10 or 15 years ago. But it kind of is revolutionary because it has 3D vision. So you put your head into this visor, you look into it, and then you control the robot from a distance. And then, but it has these wristed instruments where you can do basically everything that you could with your hands in the patient. It doesn't have a tremor and it has 10x magnification. And so here's what it looks like. This is four arms of the robot, and then they're attached to robotic arms that go into the patient. And so you can do really cool exposures, things that we would never be able to do before we can start doing. And so um, as a result of the robot, I can do sort of much more intricate surgeries. And so we do the living donor surgery now robotically. And so the patients can have um, sort of much smaller incisions. This is the incisions that an individual had after donating the right side of his liver, which is sort of incredible that they can kind of um, um, recover, with minimal sort of disability. Here's a little video of how it looks. One second. Well, you can see here, this is how the robot arms work, and something like this laparoscopically would be very difficult, dissecting out all of these arteries going to the liver, but with the robotic arms, you can dissect them out very beautifully. This is just dissecting off some of the lymph next to each one of these arteries, but every single thing that you do is very controlled, and even when you watch it on this screen, you can't get the whole benefit of the robot because half of the benefit is the depth perception and the 3D vision that you get. But you can have these and all of these structures that you're looking at are somewhere in the order of 3 or 4 millimeters, 2 or 3 millimeters. And so, you can see them with such beautiful magnification. It's really incredible. So it's allowed us to uh, do really fun things and that are super helpful. And so if you look at um, this, something like this chap here, he donated to his dad, and these are the incisions that he had. This is on post-op day one. He had this is a woman who and a chap who donated. So I'm kind of happy to talk about where are you guys now? Stop sharing. So, I can talk about my pathway, or if people want to just ask me questions about that, I'm okay with that also.
Maybe if you want to talk a little bit about your pathway, and then we can go from to questions, if you're okay with that.
Sure. So, oh, we got some pretty good questions here. Good. And so then, so I was born in England to Indian immigrant parents. So they came to England in the 70s. I was born in the 80s, and then I went to school and um, I went to, and then in England, the way that it works is that at age 17, you do your A levels and then you enter into medical school as an undergraduate. So you go to medical school at 17 and a half, 18. And then after doing my medical school, I graduated. You graduate when you're like 23, 24, and then you do your house officer, senior house officer, which is kind of like residency. But in England, it looked as though most of you guys who are on here are American graduates, but or Americans, but the difference with America and England is that in England you're not expected to know exactly what specialty you're going to go into straight out of medical school. Most people go in and do some general medical and surgical. So in my first 2 years as a house officer or a intern and resident, we did 1 year of medicine, 1 year of surgery. So we kind of get a lot of additional experience not as a medical student, but as a working doctor, as in the front lines, just kind of help us figure out where we are happy and what we want to really commit to. And then in your third year, you kind of make a decision what kind of pathway you want to go to. Do you want to go towards surgery? Do you want to go towards medicine? And then you do 2 or 3 more years of general surgical or medical training before you then commit to general surgery or orthopedic surgery or ENT surgery. So there's about 5 years after medical school where you do general medicine and surgery before you commit to a surgical specialty, and then you do about 5 or 6 years of training, and then you do specialty training. So America's a little bit more streamlined when it comes to graduate medical education, and there's a lot more infrastructure around it. So anyway, it just so happened that I moved to the States after doing 3 years of residency in England, and then I did 5 years of general surgery residency here, and then I did 2 years of abdominal transplant fellowship, and I've been a practicing surgeon for the last seven years. It's been fun. Yeah, it's a good profession. It's not as the when I entered into general surgery, I kind of understood that surgery was what I wanted to do more than just medicine, which is mainly prescribing medications without intervening. But I kind of liked intervening in a technical fashion. And then you kind of go where the opportunity is, go where you really enjoy the pathology, go where you really enjoy the operations. So, transplant, liver transplant, kidney transplant are these incredible procedures where you have uh, a kidney transplant takes 2 hours, a liver transplant takes about 5 or 6 hours. It is 2 hour, 3 hour effort where you take someone off dialysis, completely change their life. It is a 6 hour effort where you save somebody's life. And it felt like these very difficult but meaningful operations that you can perform on people that change their life. And, uh, you see the transformation even days after the operation. You can see how somebody's condition can improve significantly. So, it's quite long hours, but it's very fulfilling.
Thank you so
I
much for
would,
that.
yeah, highly recommend it.
We're going to start with the questions from the students. So this is Juan, and he's asking, in patients with hepatorenal syndrome, how do you differentiate those who will recover post-transplant versus those requiring simultaneous liver kidney transplant?
So it's very, very advanced question. So then the you can't essentially. So then people with hepatorenal syndrome is this thing where I was explaining that creatinine is part of the MELD score. And when your kidneys get impacted as a result of the liver, the kidneys can either recover after you do the liver transplant. Once you fix all of the problems, they can just go back to being normal, or they could end up not being normal for a long period of time and require dialysis. And so the question is how can we predict that? And so we can't always predict that. There are guidelines as to who qualifies. So if somebody's kidneys have not been working or look very bad 3 months before, or if they, I'm just giving you the generalization, but a longer period of time where they've had dysfunctional kidneys or a GFR of less than 20 for 3 months since the time that you before the time that you are listing the patient, someone who's been on chronic dialysis, those are the individuals who get listed for simultaneous liver and kidney. And so then when we list them, we replace the kidney and the liver. There are these individuals who then only get both a liver and kidney, both of their liver and kidney problems get fixed. Some people don't qualify for that, but will not have kidney recovery afterwards. So we do a liver transplant and then we wait to see for 3 months. If their kidneys don't recover and they remain on dialysis, they get a special mechanism called safety net kidney transplant listing, where they will get listed for kidney transplant and then they will get priority on the kidney transplant waiting list. In California, for example, kidney transplant waiting time can be anywhere from about 8 to 10 years. If you are put on the kidney transplant waiting list after getting a liver transplant, your wait time will be significantly reduced. And so even if you get a liver alone, end up with kidney disease after, you have access to a kidney transplant within a year, usually. Um, if you have persistent renal disease. The other things that predict that, if you're older, if you have diabetes, high blood pressure, if your kidneys were chronically diseased from before, it's lower likelihood that they will recover after a liver transplant.
Thank you so much for that. I see that Julie had her hand raised. Do you want to ask your question, Julie?
Sure. Thank you. Uh, Hi, Dr. Shareef. Thank you for being with us. I wanted to
Cool.
ask you about your work-life balance. If you could tell us about your sense of work-life balance, what that's like for you.
Yeah. This is it's a really interesting and important uh, question because you guys are probably, in the range of in your teens, 20s, 30s. And so you are planning your life and you're saying, I'm really excited about doing something good for humans. I want to work hard, uh, and I want to learn something. I want to be intellectually intrigued, and I want to help some people, maybe do some research, and I want to have a functional life outside of the hospital. And so uh, I have seen we used to talk about this no end in my 20s when thinking about what we were all gonna do. And so the thing that I would say is that when you are looking uh, at the start to try and plan having a good work-life balance, it is really difficult because work-life balance, essentially what we all want to do is have something that's really fun, earn a lot of money, and not work so hard. That is the ultimate quote unquote work-life balance where the thing that we do or contribute financially reimburses us, makes us, really has an impactful uh, impact, and then gives us enough finances to be able to have, a functional life outside of the hospital. But life is quite tricky in that some of the things that are really hard, uh, such as like cardiac surgery or all types of surgical procedural specialities, have a quote unquote harder schedule but are financially more reimbursing. Potentially, I'm not kind of super into the money aspect, but in terms of fulfillment, it really is fulfilling if somebody breaks their leg and you fix it. If somebody has heart failure and then you replace their heart with a heart transplant or do a lung transplant or a liver, kidney transplant and you fix their problem, it is very fulfilling. And what I would say about work-life balance is that even though a lot of my colleagues who have quote unquote better work-life balance, i.e., they can work remotely, they can work less hours, they are sometimes finding that their work is not as meaningful. And so they are struggling with this thing where they've worked for 10 years to become this doctor, and they are dealing with a patient population or a problem that they can deal with in their sleep. And they're not
Mm.
intellectually challenged, or they don't feel like they're doing in really any good for society by looking after a patient population that they're looking after. And so my personal work-life balance isn't great if you look at it from the outside, but if you look at it from uh, I'm how fulfilled I am. And, I've got two children. I have a wife. My mother lives with me. We live in San Francisco. You know, the last 10 years, have they been easy? No, they're not super easy, but there has been a lot of hard work. But now, 6 years into practice, I can do a liver and kidney transplant in half the time I could, 6 years ago. It really frees up a huge amount of time. Do I feel more confident about everything that I'm doing? Yes, hugely. And so as you get older, you kind of get things that were very difficult start becoming easier, and then the work-life balance aspects of it, um, start becoming easier. There's a lot of blessings along the way where I met my wife, we had two children. There were a lot of people supporting me, so having a good social support system and having a good professional support system is also a very important aspect of having a good work-life balance.
That was a really great answer. Thank you. That is a lot to think on. I really
Yeah,
appreciate.
it's a lot more complicated, but our brains always go to how how quickly can I get out of residency? How
Mhm,
how much is the average salary? And then,
mhm,
how many night shifts do I have to work? That
mhm.
does not equal happiness, even though we all kind of think that will. I can tell you just from looking at all of my colleagues, it doesn't necessarily equal happiness.
That's a really great perspective. Thank you. I'm gonna really enjoy thinking on that. I think it was a great answer. I really appreciate it. Thank you, Dr. Shree.
So the next question is, do you see a future where transplant allocating incorporates dynamic clinical markers or AI-based prediction models beyond MELD?
Yeah, for sure. I mean, there is a huge I just gave there's a huge amount of data that is collected in transplantation that is not connected anywhere else. And so the amount of information at the disposal of in clinical systems, in UNOS, in each one of our own clinical systems, predicting which kidney is going to be best for who should, especially for kidney, because if you look at uh, on our own kidney transplant waiting list at UCSF, we have 4,800 people on our kidney transplant waiting list. And so there's this huge number of individuals who need stuff sorted out, who needs to have things uh, allocated, and using machine, and at the moment we have a army of coordinators who go through and manually meet and check and speak to and send letters to their referring doctors and do a huge amount of work to make sure all of these people remain healthy while they're on the waiting list and make sure that they've got all of the appropriate testing done for kidney transplant whenever it happens. And so, is there a role for, automated or artificial intelligence or machine learning algorithms? There's a huge potential in transplantation. But transplantation is based on trust. The public has to be 1000% trusting of what we're doing and how we're allocating to make sure that that's why people sign up to become a donor because they trust the system will appropriately use their organ in a way that cannot be corrupted. And so, with all of the AI stuff that's that will be implemented, it's important that we maintain oversight, maintain public trust to make sure that everyone still feels very secure in participating in the transplant activities and make sure that they're trusting in it.
Thank you so much. Manasvi is asking, what drew you specifically to transplant surgery?
Say that one more time.
What drew you specifically to transplant surgery?
I don't know, so I was always interested when I started off in Southampton in England as a second year resident. There were a couple of surgeons doing hepatobiliary surgery. They were doing laparoscopic liver surgery. So his name was Muhammad Abu Hilal, and the other guy's name was Neil Pierce. And they were kind of pioneers or early adopters in laparoscopic liver surgery. So that I was always interested in liver surgery. And so when I moved to the States, there's basically three ways you can get training in liver surgery after you finished your residency. You can either do surgical oncology, which is liver or surgery for cancers. And so liver cancers are a type of um, surgery that is included in that fellowship. But you also have to learn about thyroid cancer and breast cancer and colon cancer and all types of sarcoma, everything. And so within a 2 year period, you learn about cancers all over the body, and then you kind of become a cancer specialist. And so I wasn't super interested in becoming a cancer specialist, but I wanted to become a liver cancer specialist and so hepatobiliary surgery is another one year fellowship, I think it is, where it's not uh, it's basically liver and pancreas surgery specialty, but you're not a specialist in a specific disease group. You're just a specialist in a organ group. Transplant was this great sort of opportunity that I had where you kind of are become an expert in end stage liver and kidney problems, and then in doing so, you become a expert in dividing the liver and doing liver cancer operations because of the living donor aspect. And so, um, when I moved to UCSF as a fourth year resident, sort of the group here was quite inspirational, and there's one or a few people in particular. There's Nancy Asher, who was the first woman to perform a liver transplant back in the 80s, I think. Dr. Stock, who's a surgeon and NIH researcher who's who's researched heavily in HIV and transplant. These people who I looked up to, are part of the major reason why you kind of pursue different specialties, and they really encouraged me. And when I looked at them, I wanted to kind of be like them, and then the opportunity was there, and so that's what drew me to transplant. And then the more you do it, the more you find out about it, and the more you love it. It's really interesting.
Amazing. Thank you. I see that Lena has her hand up. If you want to ask your question, Lena.
Yeah, yes, I did. Thank you. So I just wanted to ask about the experiences. So what kind of experiences did you do like prior to medical school, like community service, research, extracurricular activities, like clinical and non-clinical work? Like what did you put on your like application?
Yeah, so this comes up a lot, and so things are super competitive here. Back in the day in England, I was a 17-year-old who had only just started speaking in full sentences at that time. So it wasn't like we weren't quite as a lot wasn't required of us in England as it is of you guys here. And so the so in England we would be doing our A levels. We're 17 years old. We'd do a little bit of volunteering, uh, share some experiences and stuff, and that would probably be sufficient if we did a teeny bit of research. Now, you guys are aware that a lot of students are doing research, trying to get some experience of, what it's like to get on a publication, collect some data, do something. Um, number two is number two is to to try and get your foot in the door somewhere to kind of get some clinical uh, exposure, either through a organized or a non-organized, or through the community wherever you are, to kind of go to a family medicine, GI, whatever it is, just to get into the clinical environment to uh, speak with doctors, see what they're doing, and experience patients, um, and then extracurricular work, things like this initiative is, I'm sure it was born out of, um, so, trying to create something where uh, you really you really are invested in it personally, where probably the people who created this thing that we're participating in is, they want to get into medical school, they want to get some exposure, they have some barriers to meeting individuals. So they said, hey, why don't we come up with this thing where uh, we, reach out to 1 million physicians, and then of them, 20 of them will possibly say yes, and then we will get exposure to 20 different specialties. And then, this is something that we can put on our CV. And so the real things that stand out to people who are looking through applications ultimately is, everyone's doing some collection of things like I just talked about, but people who feel quite sincere about it and interested in it, rather than doing things to tick the boxes, are the ones or somehow uh, making it sincere, uh, is helpful, but it's hard. And just keep going at it, keep hoping for opportunities, keep looking for opportunities. But some collection of clinical experience, some innovative thing to show that you can show some initiative, some clinical thing, and then hopefully something charitable, something that kind of makes the world better, is what I think most people are looking for.
Oh, okay, thank you. That sounds good. Yeah, because I was a little bit curious about that. And when you came from Europe, did you have to do like years difference to become a physician here?
Do I have to do what difference?
Like years, like when you finished medical school there, did you come do residency here in the US?
Yeah, yeah, yeah. So I did 3 years there, and then I started here again at age 26, and then I had to do 5 years of surgery residency, and then 2 years of fellowship. But
Oh,
and even again, the similar question that you ask is like, oh, how many years did you have to do here? How many years? There's this race to finish training. I don't know what drives that race for us to tr finish training. A lot of us want to quote unquote move on with our lives, but really on the other side, it's not that fun. And so it can be fun, but it can also be quite fun training. And so um, now looking back on it, it feels like it's gone by in a blink of an eye. And so I wouldn't worry, even if sometimes there's these opportunities to take out 1 year to do research or to get some sort of extracurricular activity. If you have those types of opportunities and you are really into it, don't hesitate about 1 year here and there if you're really gonna put 100% effort into it. Because, you know, a year here and there doesn't really make that much difference. It's actually, if you're into it, it really is really fun.
Oh, okay. Thank you very much.
I don't know if that made sense.
The next question is from Danielle. And what factors can make someone ineligible for liver transplant besides the MLD scores?
Ineligible or eligible?
Ineligible.
Um, sorry, I missed it. Is it IN eligible or eligible?
No, no, ineligible.
Ineligible.
Yeah, sorry about that.
So, so there's a lot of things that make them eligible, but basically, we want somebody to, we want to help somebody by giving them a liver transplant. And so if the ineligibility criteria come and so we want to help people with liver transplant, and we also want to we have a responsibility to um, make sure that the organ that we are taking, both from a living donor or from a deceased donor, is used to its best ability. So, if you imagine somebody with pancreas cancer that's metastatic to the liver and they have a life expectancy of 3 or 4 months, doing a liver transplant for a systemic disease to remove liver metastasis, even though there's a systemic portion to that cancer, there's no point doing it. So that person, metastatic disease is ineligibility. But if you have liver cancer just in the liver, hepatocellular carcinoma, or very strictly based metastatic diseases such as colorectal cancer in certain situations, what what the ineligibility comes in that, are they going to not benefit for a extended period of time that allows them for us to put someone else, a living donor, through a risk, or a deceased donor's tissue for this person to really get benefit from it. And the other reason that we can't help individuals is that if their lungs and heart or brain is so sick from their liver disease that they have a high likelihood of dying around the time of the surgery, then we won't subject them to the surgery, potentially uh, be a futile use of liver, and that they were going to die or become worse as a result of the surgery. So we have to make these decisions where we have to predict on how likely they are to survive the surgery, if their heart and lungs and etc. are strong enough, and if they're not strong enough, then they can't be eligible for uh, transplant. And then the other final thing is that if they need to not only be able to support themselves through liver transplant, but they need to have insurance, etc., to pay for immunosuppression medications for the remainder of their life. There's never a situation where you can um, come off immunosuppression. So making sure that somebody has appropriate resources to support their immunosuppression in the post-transplant period is something that we check for. And we also try and make sure that there's enough community members that can care for this human being, because it's kind of a difficult transition when we do a liver transplant, and then or a kidney transplant for that matter, and then they have to go home after their hospitalization. They need some help at home, and so we really need to make sure that they've got people around them to care for them, especially for the immediate post-operative period. And sometimes some people don't have anyone, and it becomes very difficult to risk doing a surgery if they haven't got anyone to care for them after surgery. Those are some of the things.
Thank you so much. The next question is, what is the primary factors driving the superior long-term graft survival seen in living donors, transplants, compared to diseased donors?
It's basically, living donor is planned versus deceased donor is unplanned. And so it's we, if you imagine somebody comes to see me today in the clinic with a MAEd score of 15, and they say, I feel terrible, my belly's filling up with fluid, I'm confused, I've had a few bleeding episodes, I go into the hospital every other week because I have pain. And I say, well, I know you have all of those symptoms and I know your life is horrible, but you have a MAED score of 15, and our average MAED score at Transplant here in San Francisco is 32. So I'm just going to treat you and wait until your MELD score gets to somewhere around 30, and then hopefully you'll be well enough at that point in time for me to do a liver transplant. And so this person may live this incredibly difficult, terrible life for the next 5 or 10 years, and then in 8 years' time might get a terrible infection of their fluid in their belly, and then their MELD score goes up, and then I do their liver transplant 8 years after suffering, going through all of the illnesses. The alternate is that that same person comes in and says, my daughter wants to donate to me. She's 25 years old. She has a perfect liver. And then the following week, we do their liver transplant. So that person's illness arc hasn't, they haven't lived with illness, liver disease for like 10 or 15 years. They've lived with it for a couple of years. You do a transplant and then they normalize straight away. So they haven't had all of this degradation of their heart, their liver, their kidneys. The whole body becomes weakened from having this chronic disease for a long period of time. So usually, and the same thing with dialysis, is that if you have a living donor and you get your kidney transplant pre-dialysis, so they know their kidney function is getting worse. They know that if they continue in this trajectory, they'll probably be on dialysis in 6 months' time. We say, okay, if you've got a living donor, um, we will do a living donor kidney transplant in 3 months, so you never go on dialysis. As a result of that, their heart, their lungs, their kidneys, is not impacted by dialysis. The other thing is that the organ comes out of one human and goes into the other human 30 minutes later. Living donor surgeries happen simultaneously, where the liver comes out in one person's room as it's coming out in the second person. And so soon we take it to the room next door and pop it into the new person. The kidney comes out of the donor and goes into the recipient in the next room straight away. Whereas with deceased donor, a deceased donor may be in Southern California this afternoon. The donor will happen in Southern California at 4 o'clock. They put it on a plane at 9 o'clock. It gets flown to San Francisco at 10 o'clock. And then we put it in about 2 o'clock in the morning. So there's 9 hours where this liver's been in an ice box, or the kidney's been in an ice box. And so all of those factors mean that living donation usually we can get to people sooner, the organ quality is higher, the cold ischemic time is lower, and the outcomes are usually better as a result.
Thank you so much. There's another question right here. Manasvi, Your work on renal allograft rejection sounds really interesting. Based off this, what do you think is the most promising direction for reducing rejecting rates in the future?
This is what people have been working on for for many years, but reduction, the major thing is there's a burden, there's a lot of illnesses that people have as a result of immunosuppression. So there's one field of study where people want to get a kidney, not have rejection, but also not take a huge amount of anti-rejection medication. So that is a field of study where you use the immune system, you use different pathways with different immunosuppression medications which protect you against protect you against rejection, but not have such toxic effects on your rest of your body. There's another field of study where they say, okay, well, how can we monitor kidneys with non-invasive um, markers, cell-free DNA, other types of markers, so that we can keep a really close eye on the kidney itself, rejection episodes, and reduce the standard immunosuppression that we're using at the moment. How can we reduce the amount of biopsies that we're doing in patients? And then there's this other field of transplant where there's xenotransplantation, where they are like, well, there's 4,000 people on the waiting list. Somebody has to die before they get a kidney. How about we grow kidneys in animals, in pigs, namely, genetically modify them and give them immunosuppression, and uh, to transplant across species is a whole different animal, quote unquote. And so there's a whole field of study to try and really make sure that these genetically modified xenokidneys are are safely able to be used, which could revolutionize our field, and that it could really make it exciting for, that there would be possibly thousands of more kidneys available for all of these poor folks. Um, xenografts that, if we can make sure that they're immunosuppressed, make sure that they are not getting any, animal infections that we are unaccustomed to, it would be an incredible situation. So the bottom line is that there's a lot of different directions that we can go in to hopefully help a lot more people. Oh, I think you're muted, Jennifer.
Sorry. Sorry, the next question is, during robotic dissection of the hepatic ileum, what are key landmarks you rely on to safely distinguish the hepatic artery, portal vein, and bile duct?
You know, it's um, it's uh, it's like walking around your house uh, at night. Uh, you kind of once you've walked around your house at night enough, then every time you go to the bathroom, you don't have to turn all the lights on, and even though uh, you kind of get a feel for where the door openings are and where the light switch is and how to, where the thing to flush the toilet. And so the same thing happens if you do surgery for a long period of time. It's like walking around your house with the lights off. And so you study where things are in a book. You study where they are specifically in a patient with on a CT scan with contrast. So you have an idea where all of these things are. And then you kind of have to be good at dissecting tissues, which is what you learn throughout all of your surgical training. And then you kind of develop where your home is. So my home is the liver, my home is the kidney, and the abdomen. And so you kind of get very accustomed to where things are in your house. And so, it basically looks like It looks like like a fatty blob when you first get started. Let me see if I can. So if you see, um, let me see if I can show you a part where you have the hilum first. Yeah, so then if you see here, okay, well, I can't necessarily show it to you now, but basically, if you see this thing here, this is the untouched left side of the liver, but you see there's all of this fat and lymphatics that are over the top of things. You can see that there's pulsations, but the relative positions of things are that the portal vein is posterior, it's right at the back. The bile duct is on the medial aspect, and then the hepatic artery is on the left-sided aspect. And so you kind of have this map in your head, and then you have all of this fat over the top of it, and then you just have to dissect it out to kind of based on where things are. You get better at it the more reps you do. It takes a bit of time though.
Thank you so much, and bless you.
Thank
The
you.
next question is there anything you wish you knew prior about transplant surgery?
Mm. No, I don't think I can, the thing that I know, I think that I appreciate now is I think I would be, the thing that I appreciate is some of the people that I work with are 75, 74, 70, 65, and they are still excited about coming into work. And the reason that they're still excited about coming into work is that it's ever evolving. And so that, we always, when you're like 20, you think to yourself, oh, how can I quickly get into medical school, quickly get finished with school, and then start earning some money. Then you have this middle period of life where you need to get out of the hospital as quickly as possible because you've got kids or you've got a million other responsibilities to do. And then there's this period afterwards, once your kids have grown up or all of those other, and then you think to yourself, oh man, what do I have to do with myself? And so you want something super exciting or, you want to start contributing to society even when you're old. You don't want to be like one of these old non-contributing people that just walks around aimlessly with their mouths open. And so, transplant is this great thing where people who are old, who have been in it, still are excited about new developments. They're still excited about research. They're still excited about clinical advances. And so it's a really exciting field that I don't think even if I spend the next 40 years in it, I will have covered every aspect of it. There's like, it's really cool. It's got ethical considerations, scientific considerations, clinical considerations, humanistic considerations, robotic considerations, clinical. So it's a very wide-ranging, really super interesting field.
Thank you so much for that. Julie has her hand up. like to ask another question?
Yes, thank you, Jennifer. Hi, Dr. Shareef. My question is about what would you say are maybe the biggest opportunities in your specialty in the next decade, or really any that come to mind?
Yeah, I think, as it was alluded to, it is um, artificial intelligence and the uh, role of AI in medicine basically is there's a huge amount of data is basically coming up with a solution to a problem. And so there's a lot of problems in medicine. There's a lot of problems in transplantation, fair allocation, one of them that was already mentioned, organ availability, uh, this thing about which organ and which patient is gonna get the best outcome for that organ. This notion of recipient organ and recipient matching. All of these aspects of transplantation, I can see there being huge growth for us to get better at it. At the moment, we say, well, what's the fairest thing about this? Well, it's fair if you've been on dialysis for 15 years and that person's been on dialysis for 5 years. It's probably, let's give it to the guy who's been on dialysis for 15. That's basically what we do at the moment. Whereas that particular kidney may not be best for the dialysis on 15
Mm.
years guy, but we give it to them anyway because, that's the way we do it. And so really studying this stuff and really coming up with super fair ways, super effective ways to utilize every single thing is probably going to be powered by people who have an appreciation, who have a respect for the field, and then have skills in, automated or artificial intelligence, etc., to be able to then use their knowledge to be able to create algorithms that can then help with this kind of stuff. And then from a clinical perspective, robotics has a huge impact. I go to King Faisal Hospital in Riyadh to train with the individuals there. They've done over 2,000 living donor hepatectomies. I think they've done about 200 living donor recipients, and so they're doing a lot of incredible stuff with minimal incisions, which I personally couldn't even imagine people would be able to do 5 years ago. So part of it is having a good imagination and having a sound ethical framework that you put your good imagination on. And so if you're doing it really for the benefit of human beings, all of you young folks, really thinking to yourself, what can I do to help people better? The world is your oyster.
Very cool. Very interesting. Thank you. That really helps me get a better perspective on like what you see as kind of how AI might affect it and just a better perspective on the specialty in general. And I really appreciate you sharing your perspective and the outlook you have. Thank you, Dr. Sharif.
Yeah, no worries.
I think Gabrielle had her hand up. Her question.
I did. Hi.
Hi, Gabrielle.
My question is, do you believe with all this new tech and AI that you will ever have to fear that AI is taking away from your job or taking away from you performing these complex surgeries?
Yeah, I mean, fear is the wrong word. It is, don't be scared of anything. And so, it is, you just have to be adaptable. You got to be, you never, you know, I think having people who are care for human beings, like in medicine, that's what we should hopefully be doing, and are knowledgeable in the field can help direct how uh, some of this technology is used. So if you have a whole bunch of radiologists uh, that are missing a certain thing when they're scrolling through a CT scan. If a computer can go through and screen for me, uh, 1,000 different things where the human brain can only do 100, and it needs 10 minutes of training, whereas the human being needs 30 years of training. Is it helpful to the computer helps a human become more efficient? Yes. Am I worried that it might replace a doctor? Maybe, but rather than fearful, especially if a young person like yourself, I would be embracing of it and see how we can do this in a ethical, caring, responsible way to embrace all of these technologies, make sure that the right people are making the decisions in terms of how this technology is being used. But don't fear anything.
Thank you very much. I appreciate your view.
Okay, the next question is from Zaina. On a day-to-day basis, how important is intellectual challenge for you? Do you prefer the predictability of routine cases, or do you find the unexpected more engaging?
Yeah, I mean everyone's different. I never saw myself as a big intellectual growing up, but then as time goes on, there's things about each specialty that are different. Like liver transplant or kidney transplant, when I call in a patient for a transplant, I know at the when I'm going into the operating room, I am going to do this procedure on them 100%. It's been planned out, the patient's been worked up. Is it intellectually challenging? Massively. Is technically challenging? There's going to be little bits and pieces of uh, challenge that you're going to face, both from a planning, cognitive, intellectual, technical that you do. That's what makes it very interesting. But it is, I only do 4 or 5 operations. That is a very narrow scope of practice. Whereas somebody who does general surgery does, tenfold more surgeries. They might do 40 surgeries on a regular basis, and they have more diagnostic quandary. Um, and so, yeah, there's something to be said about what you're saying is that it's very difficult to predict what kind of person you're going to be, even now, what really gets you excited and what really doesn't, because a lot of things that really get you excited, you haven't experienced yet. And so, being open to all of the things, but intellectual curiosity, I think, is probably going to lend to a longer and more fruitful career than something. If you can do your job with your eyes closed a year or two after you finish your residency, it probably is going to be an easier life, but a much more mundane life. And intellectual curiosity will mean that there's going to be a longer, steeper learning curve, but a curve that gets more and more, that will keep your career kind of interesting for longer, but, a little bit more difficult to deal with.
Thank you for that. This is going to be our last question. You're involved in both surgical education and global health. How do you ensure that training programs are culturally relevant and sustainable when working with international partners?
I don't know. It's difficult. You essentially, a lot of the work in global health that I do is to, essentially copy the ideas have that have been effective in the United States, and then go out to places like Tanzania or Pakistan or wherever else where they have less resources, less finances, but incredible amounts of enthusiasm and incredible amounts of intellect and interest, and try to understand how we can recreate the important parts of what we do, like in surgical simulation or some of these technical curriculums that we teach here in those separate areas. And then it's to kind of identify a local team, educate them, and then kind of let them run the show and just be there to support them, and then kind of go in without any bias and to, really listen to this group of skilled individuals, kind of empower them with the knowledge that you have, and then let them uh, resource those individuals, but then let them run the show so that it's, culturally and, socially uh, appropriate for where they are in the world and things that are important to them. But, from a medical and educational evidence perspective, accurate, so that, it's still efficacious in the same way that it was in America. That makes sense.
Thank you so much. All right, guys, thank you so much for joining today's session. We're grateful to have Dr. Syed join us and all your thoughtful responses. We love hearing from you, and it was inspiring to hear from your journey and also have you answer questions students had. I see that we still have some questions unanswered, so please feel free to email those questions to info@prehealthshadowing.com or email, and we will try to get them answered. Now I'm going to wrap us up with our end of session slides. Let me see. Here we go. Let me share. Okay, so here we go. Sorry, let me. Sorry. I don't know why I can't get it to get bigger. Here we go. Sorry, guys. Okay. Okay, so as we do our reflection, as we wrap up today's sessions, take a moment to reflect on our journey together. Think about what response resonated with you the most. What was their particular moment example that truly captured your interest? Feel free to answer the questions in the chat and share as a reflection on the PHS website. Sorry. Sorry, guys. Okay. I don't know why I'm sorry, I put the wrong one on there, guys. Sorry, there we go. I don't know why this one isn't. I can't make this one a little bit bigger, so okay.
That's okay. This looks good.
Okay. So just to share insight, please, you can do that on LinkedIn. We'd like to hear about your experience, and it's also a way to network and also let others know about your experience in pre-health shadowing. It's a good way to amplify conversation. It's a simple act on significantly enhancing your professional network. I would like to repeat that if you're interested in becoming part of pre-health shadowing, you can do so remotely and contribute from anywhere in the world. To get started, just register on our website to gain valuable experience and make a positive impact in pre-health field. If you have any questions, please feel free to ask or visit the website for more information. Once again, if you can please consider to donate if you can, whether it be your time or money, we'd really appreciate it. We're completely free, volunteer-based, and this is really helpful to get this out for future pre-health students. The thing that we're all here about is to really want to know is don't forget to take our post-shadowing assessment available for the Dr. Syed session on pre-health shadowing website. By completing this, you'll receive a course certificate completely free of charge. The assessment itself is a simple 10 questions. This assessment is multiple choice, quiz-based on the presentation. This is a fantastic opportunity to add to your professional credentials and showcase your commitment to learning. And if you missed any of this live, we have it on our website. You can visit our YouTube channel and also pre-health shadowing to watch any of the previous sessions for free. Remember that our goal is to provide accessible learning opportunities for everyone, so feel free to explore the channel on your own pace. Be sure to catch our next session, and also please Thank you so much for joining. Also, if you have any questions, feel free to stay after. And that's it. Thank you so much.
Thank you, Dr. Shareef. Thank you, everybody.
Thank you.
Thank you.
Bye.
Bye.
Gabriella, I see your hands raised. Is there something specific you wanted to ask last minute?
I actually wanted to ask you, Jennifer. So I saw this thing on the website for previous